Hey everyone. I don't know if anyone is here yet. You have to forgive me. I am not the greatest with technology, but I am trying. I see that Georgina has joined. Hi, Georgina. And Ella, Katie, Christina. Okay. Let me just see who else is texting me. Okay. Okay. I want to say hi to everyone who's joining us. And let's see. I need to add our special guest, and I need to figure out how to do that. Our special guest today is, let me find all that information, so forgive me. It's Dr. Kristin Rojas, and I need to add her. So let's see how I do this. Let's see. Maybe not. Okay, for my techie people who are on here, please. Oh, there she is. Hi, how are you?
Hi, I'm great. Can you hear me all right?
I can hear you, and you can hear me too, I hope.
Yes.
Okay, so we have a lot of people joining on, and just for our viewers here to know that we have never met before, so nice to meet you, and we're gonna get to you in a second and hear all about what you do and what you recommend to a lot of our viewers. Just to introduce myself to you, for those that don't know me, I'm Leslie Coppell, and I'm a psychotherapist in private practice in Manhattan, and I'm also the head of the social work board for the Bone Marrow and Cancer Foundation, who has put together this wonderful presentation and the CancerBuddy app, and that's why we're here today. So I am joined by Kristin Rojas, Dr. Rojas, who we're going to just have a nice conversation. But for those just joining us, and I see a lot of people are logging on, so we're going to have a nice active conversation. Um, Really, the conversation today is to talk about sexual health and well-being and getting back to a sexual place after treatment or during treatment. And we have you, Dr. Rojas, as our expert in that. I see some of it, just so you know, in my private practice, where um, people may have gone through treatment or currently going through treatment and want to know more about getting back on track. And we'll get to what I see in my practice, but I want to start with you. And I'm going to let you do a little brief intro yourself. I think it's better. So just wherever you want to start is great.
Sure. Well, first, if you have a problem hearing me or something happens with our connection, please feel free to interrupt me at any point. My name is Dr. Kristin Rojas. I'm thrilled to be here. Thank you so much for inviting me. I am a breast cancer surgeon, but also a gynecologist. And so I live here in Miami, Florida, where I work at University of Miami, Sylvester Comprehensive Cancer Center, where I run a program called MUSIC, which it stands for Menopause, Urogenital, Sexual Health, and Intimacy Clinic. So I help treat women with a history of any type of cancer who are experiencing sexual dysfunction, which includes vaginal dryness, painful sex, low desire, and I also help guide patients in the right direction with regards to fertility concerns.
Okay, great. So you see a lot of patients in your practice who, I mean, who is the typical patient that comes to you um, with these kinds of concerns?
Well, because I'm associated with, or I work at an NCI designated cancer center, I see patients that have all different types of cancer, very rare tumors like sarcomas. I see a lot of patients with hematologic malignancies, leukemia, lymphoma. But the majority of and some patients who have had bone marrow transplants who don't have a history of malignancy uh, from other issues like autoimmune disorders. And but the majority of the patients that I do see are women with breast and GYN related cancers. But I am lucky to be able to see such a broad range of patients. And some of the um, help that I can give them really is very standard across different disease types. And sometimes it's a little bit, we can offer more tailored treatment plans based on, because we work really closely with everyone's oncologists, based on that particular patient's most recent treatment, what their plan is, what they've gotten in the past, and what their goals are.
Okay, great. So you really see a full range. Here's a funny question for you. Do you only see, I know you're in women's health, do you only see females who are going through or have gone through treatment and want to get back on track sexually? Or do you ever see, men in your practice? Do they come to you?
I see women, which includes trans patients, but for the men who are experiencing, patients who identify as male, who are experiencing sexual dysfunction, we have some wonderful urologists at Sylvester that can really tailor there's like male anatomy specific concerns for those patients. But in music, I do often, like, partners are welcome to join. So we have patients who might bring their partners, there is an actual exam involved in these visits. I tell patients to think of it like a super subspecialized GYN visit.
Mhm.
So for the exam part, I do like for it to just be me and the patient, and my nurse, obviously. But for the education part, oftentimes patients want to have their partners involved. And I've felt that it's also very helpful because usually partners want to help. They just don't understand and don't know how.
Right. So that's great that you bring that up, because I think we have a fair amount of men on our site today. So hi, guys. Hi to everyone who's here. And I
Yes.
think it's helpful for men to hear what women are going through. And, for me as a therapist in private practice, I'll be interested to hear how you define it, but we can redefine sex after cancer. It's not, it does, yes, intercourse may be the end goal for many, but there are many steps along the way. Oh, hello, who's your puppy?
Yes, she's like asking for attention, so she's going to sit on the live with us if that's okay.
Here.
You know what? I think that a lot of the things we're probably going to talk about focus around like talking about sex, talking about it with your providers, what questions to ask. And I think that applies to everyone. And also, I like that I hope the men stay on because I think that, I think that it's helpful to talk about these taboo topics in general and like to just continue to start the conversation. And hopefully, I can also direct any specific resources for them if needed.
Great. Okay. So when someone comes to you, do you broach this topic, or they come to you with this specific topic, which is what? Like, define what most people come to you with.
Well, most of my role at Sylvester is as a breast cancer surgeon. So every day except Tuesdays, I'm acting as a breast cancer surgeon. So I'm seeing patients with breast cancer, treating them, going to the operating room. I ran from the operating room today, actually. But on Tuesdays for the music program, I have two wonderful nurse practitioners that also work with me so that we don't have a waiting list and people can be seen very quickly. But usually, if they get to this program, get to these visits, they've already either asked a question to someone or one of their providers thought it might be a good idea for them to meet with me. So usually the conversation has already kind of been brought up at some point. But I do, when I give talks like this, I often get asked, like, when is the right time to bring it up with your provider? And my answer for that is all the time, every visit with every provider.
Mhm.
You never know who's going to be the one that's going to give you the resources you need. It doesn't necessarily have to be your oncologist. It can be your GYN, your primary care doctor, your psychiatrist, your psychologist, your anyone who takes care of you, the social worker. And some patients get like really flustered responses from their oncologists who tend to be like very busy. But I think that we're talking about this more now. We're all human, but if 5 patients ask an oncologist about their vaginal dryness and painful sex that day, like, they're going to go home and they're going to pull together those resources for their patients, so they'll be ready for you next time. So I tell patients, you know, you've gotten through cancer, like you can do anything. So who
Right.
cares? You know, just bring it up. Even if you get an awkward response at first, keep bringing it up.
Right. I love that mentality. And I think so many of the patients that we see and that we help are able to feel bold enough to say something like that. But um, I also think we have a fair amount who are not comfortable bringing this up because it's sort of taboo to talk about sex. And a lot of people I see think they can't bring it up because they're supposed to just be grateful that they've been treated for cancer and they're moving on. And well, maybe I don't want to, bring this up and sort of go backwards that way. So I love that you say just be bold and just do it. But any other tips you have for people to communicate this with their doctor? Like, would you say perhaps it might be a good idea if anyone is listening who's not comfortable bringing it up, maybe to send a quick email or through the portal, even to the nurse practitioner, something like, hey, I'm not really comfortable about being the one to bring this up. Can you, would you think that's a good idea, or how else would you suggest?
Yeah, that's a great point. I think that usually when I'm in clinic, I'm part of a team, right? So it's me, it's my advanced practice provider, my APP, our social worker, my nurse. So if you don't want to bring it up with the first person that walks in the room, you can always say, "Hey, would that be okay if I talk to your nurse, your NP, your PA? I have some questions for them." And if it's a woman and their oncologist is a man, you can literally just say, like, it's about women's health stuff. And they'll be like, okay, okay. And they'll know exactly what you're saying, and
They'll
they'll find the right, yeah.
let the women handle it. But no, I'm kidding. I mean,
Well,
hopefully.
and vice versa, for the men, you can also do that too.
Right.
But I think that now oncologists are being trained and educated on how to respond to these questions and get these resources together for patients. So I think it's evolving.
Mm, okay. That sounds good. So hopefully, anyone out there has heard that it's a funny topic to bring up in a way, but it's part of life. And I want to get to some of the questions that some of our ambassadors have sent to us. But before I do, I guess I will tell you what I see in my practice and what we talk about. And maybe that's, something that you can talk about too, which is, I touched upon it a second ago, was, people see, or many people see sexual intercourse as the end goal and they're reaching for. But perhaps along the way or post treatment or while they're on treatment or even when they're done, maybe they don't get back as it was before. So I know that I talk to people about being creative and inventive and maybe redefining what is sex. And of course, to me, there's a lot more to sex than just that end goal. There's, intimacy and affection and hand holding and all of that, but that's more flowery. I don't know that something that you discuss with your patients.
Certainly. First of all, let me say I'm so glad people like you exist in the world that are the ones talking about this and highlighting this specific concept. There are so many different types of intimacy that are not sex, and there's so many different types of sexual activity that's not penetration. And we
Mm-hmm.
do talk about that a lot because depending on a patient's situation, what surgeries they've had, or what kind of treatment they're on, it may not be the right time for them to engage in penetrative intercourse or that particular activity. But there are a lot of alternatives in that sphere. But there's also ways to be intimate that aren't sex. Exactly.
Right. And I think it's so important to bring that up and to talk about it because, of course, it's those little steps that in time will lead to the bigger step of whether it's intercourse or something else along the way. But it's as most of us are, most here, maybe women on this call, there's an emotional component to sex, and that is a big part of it. It's not like, okay, I've had this treatment for all this time. Now the doctor says I'm cleared. Let me just jump right back. It doesn't work like that. Do you want to talk about that and maybe make some suggestions of things that you recommend that can help our patients get to that point?
Definitely. Well, first, I think it's really important to kind of establish what a patient's goals are when they see me. Because, while many patients do want to get back to a place where they can have sex without pain, because that's a lot of what I help patients with is addressing that specific issue.
Mhm.
Some patients, it's more complicated. They're like, well, I don't really feel like it, but it's important for my relationship and my support system to be able to do this.
Mhm.
And so they need help, number one, communicating about that, but two, also have similar goals, although kind of in a different context. But I do have some patients who are like, listen, I used to be like this and I want to get back to that. And I kind of have to say, okay, let's go step by step. We maybe can't get you back to exactly that, but we can definitely work on getting you to a place where things are more functional and at least where you're able to not be in pain.
Right. Right. Okay. So I'm looking at some of the questions. So
Yeah.
forgive my going to the side here, but some of our questions that maybe you can get to. What can you use for lubricant after treatment that will help you with vaginal dryness?
Yeah. So patients present to music with most patients have three common symptoms. Number one, vaginal dryness. Number two, painful sex. Usually these things are related.
Right.
And three, low desire. So a lot of what we do is talking about how to address those first two, which is usually when we examine patients, we find that they have something called genitourinary syndrome of menopause, or GSM, which is the new term for vaginal atrophy, but it's like not necessarily a patient-friendly term still. But it
Yeah.
basically is this umbrella term that encompasses things like dryness, painful sex, recurrent bladder infections, itching, irritation, things like that. And so we because that's the most common concern, we have developed a simple 4-step treatment plan for most patients. Okay.
Mm-hmm.
Number one is eliminate irritants. 2, moisturize. 3, lubricate. And 4, address the pelvic floor. Sorry, my dog is trying to unplug my ring light. Sorry. So number one, eliminate irritants. So many patients, because they start to feel these symptoms, they use a lot of different products that have artificial fragrances, alcohol-based wipes, bath bombs. There's a lot of really irritating things in bath bombs. And so the first thing we do is take an inventory of everything that's touching the delicate skin of the vulva and the vagina.
Mm-hmm.
The vulva being the outside, the vagina being the inside. This even means harsh soaps. Even if there are soaps that say that they're for babies, it doesn't mean that they're supposed to be put in the vagina. Because the vagina is actually a balance of good and bad bacteria, the good bacteria being lactobacilli, a lot of those products killed all the lactobacilli and start this cycle of irritation and inflammation that manifests as burning and stinging. So patients that have a lot of burning and stinging, sometimes that's related to something that's touching that area. And that includes artificial fragrances and the detergent that they wash their underwear with, formaldehyde in toilet paper, bath bombs. I know I said that already, but I can't stress it enough how bad bath bombs are for the vagina.
Right.
And so that's step one. Oftentimes when we have patients kind of back off those, a lot of their symptoms get better, believe it or not. We can develop allergies to a lot of these long name chemicals that are in some of those products that are actually illegal in Europe. The United States doesn't do a great job regulating feminine hygiene products, and we're actually exposed to a lot of chemicals through the vagina. Number two is moisturize. So think of moisturization like maintenance. So just like we're putting our under eye cream on at night, we're going to think about treating the vulva the same way. So when you get out of the shower, at least 3 times a week, think about putting something on the vulva, the external vagina, that's like an emollient. Like we love single ingredient organic coconut oil. Solid at room temperature, same stuff you get at Trader Joe's or Whole Foods. You rub it in your fingers. Huh?
Same stuff you would cook with?
Mm-hmm. You just want to check and make sure it's organic and it's the only ingredient on the bottle. Yeah, or the jar.
Okay.
And it's the same stuff. And actually, coconut oil is a natural antimicrobial, antifungal. So it actually helps kill some of the bad bacteria while promoting those good bacteria that decrease inflammation. So moisturizers for maintenance. So you need to look really carefully when you're picking a product for dryness to figure out whether it's a moisturizer or a lubricant. So moisturizers we do all the time, whereas lubricant is something that's supposed to make everything really slippery to decrease friction. So anything that's going in the vagina, or not even going in the vagina, but anything touching the vagina should should have a lubricant.
Mm-hmm.
Lubricant, same concepts apply. We don't want long name chemicals. We don't want gimmicks, warming, flavors, all that stuff. We want basic, paraben free, long name chemical free. We love Uberlube in the music program. It's a silicone based lubricant, super slippery. It's got vitamin E in it. It's very moisturizing as well. But some patients need, and that's a silicone based lubricant, but some patients need water based lubricants. Water based lubricants are for patients who are using.
How would one know the difference of what they need depending on their symptoms?
Yeah. So for patients who are depending on condoms for STD or pregnancy protection, if they're using certain non-latex condoms, it may not be compatible with certain silicone-based lubricants. If you're not sure, you can always go to the lubricant website and go to the FAQs. And usually the question is, are they compatible with condoms?
Okay.
Yep. Speaking of condoms, you want to pick one if you're using them that does not have spermicide, because spermicide can.
Oh, did we lose you? Uh-oh. Dr. Rojas?
I'm here. Can you hear me?
Yes, we lost you for a second, but okay.
Sorry about that. What was the last thing you heard me say?
We were talking about spermicide.
Yes. No spermicide for patients with dryness or painful sex. So, yes. So we really promote silicone-based lubricants unless patients need water-based. Good brands for water-based lubricants are Good Clean Love, things that have like none of the extra gimmicks and stuff we talked about. And then the last step is addressing the pelvic floor. So a lot of patients don't realize this, but if they haven't had sexual activity for a long time and have a lot of dryness, the pelvic floor is like a basket of muscles, woven muscles together. If they've had episodes of painful sex, then some of those muscles can spasm and cause a lot more pain when they try to engage in sexual activity again. So we talk to patients a lot about using sexual devices like dilators, vibrators, things like that to increase blood flow, gently stretch the tissues, and dilators can also be helpful for patients when we're trying to teach them how to relax the pelvic floor. This is for a lot of my patients who are like really into Pilates too.
Right.
They have like very tight cores.
So
they have,
it's almost too strong.
yes, a lot of times, you know, we've learned, you probably heard, and people probably heard about Kegels. Like everyone's like, do your Kegels, you know, where you're tightening the pelvic floor. We actually want patients to get really good at relaxing the pelvic floor. And the way that we cue them to do that is by thinking about relaxing your inner thigh muscle. And if you can think about relaxing that muscle, boom, your pelvic floor is relaxed. Because it's hard to just snap your fingers and relax your pelvic floor.
Right. That's interesting. Okay, I think I was just trying to relax my thigh myself.
Yeah, you take your two fingers and you can place it on your inner thigh muscle. And if it's tight like a guitar string, your pelvic floor is tight. So you want to focus on relaxing those muscles, and taking a deep breath. Meditation podcasts can be really helpful. Mindfulness, getting in touch with your body. And then sometimes it's helpful to place a dilator after doing those relaxation exercises.
Okay, great. How many people just did that with their thighs? I did. Oh, thank you, Hannah. She said so helpful. I'm trying to read as we're going through. So I know a lot of you have made little comments, so thank you. Someone wrote earlier about the bath bombs, and I think that was probably really helpful to know that. We think of baths and bath time as relaxing, and we want to have a fragrance, but that really could back. Okay, so let me see what other. So a few people asked about getting the sex drive back.
Yeah.
And that probably I would think less biological and more psychological. Oh, someone just wrote, what about having zero desire for sex? So good time.
Yes, this is a great question. And so the first thing is we have to fix the pain. Like if patients are having pain, your body's not going to want to have sexual activity. So we focus on all those symptoms that I talked about already, but then it actually is two things. It's complicated. It's psychological, but for many patients who've had cancer treatment, it is also biological.
Mm-hmm.
Like even if patients are younger than the normal menopausal age in the United States, which is 51, 52, if you've gotten chemo and a bone marrow transplant, you may have been put into early menopause. So even though you're in your 30s and you're not having periods, your estrogen levels are very, very low. And if your estrogen levels are low, your natural testosterone levels are low. And women actually do have really low levels of testosterone that help with libido.
Mm-hmm.
So there is a biological reason a lot of times combined with all the psychological stressors that go along with it. So it's very complicated to get into that. That's why it's so helpful to have people like you who are really good at that aspect.
We go right in, no pun intended.
Yeah. For the biological part though, patients, we do some lab tests, specifically test patients estradiol and another hormone called FSH, or follicle stimulating hormone. If they haven't had periods and their FSH is really high, usually that means they're in menopause, and they would benefit as long as their cancer isn't sensitive to estrogen. Then we can give them back estrogen plus or minus progesterone, and they start to feel a lot better. There's actually estrogen receptors in the brain. So when women have like all of a sudden very abruptly low estrogen, that can cause depression, mood symptoms, irritability. Like there's a biologic reason for a lot of those symptoms. I think that's really helpful for some patients to know. It's not all in your head, although it is complicated.
Right. So someone just asked, my doctor has talked about hormone replacement. Could that help? And you're
Yeah.
saying, and as long as certain other things, are and you're a candidate for that. But
Yeah.
something good to bring up to your own doctor, like, because that could really help.
Yeah, so patients who have a history of like hematologic malignancies like leukemia, lymphoma are great candidates for hormone replacement therapy. We usually start with a little estrogen patch, and then we may or may not give them a progesterone pill. But sometimes if patients have had blood clots in their lungs or their legs, they're not great candidates for hormone replacement therapy. The other thing to keep in mind is that bioidentical hormones is a marketing term. There is no evidence that bioidentical hormones, these like special recipes that people will make for you, are any safer or any more effective than standard FDA approved hormone replacement therapy.
Right. So you're saying like you really should stay with the FDA approved because you don't know your risk for different things like blood clots and things like that.
Yeah. So estradiol is the FDA approved version. It's the same thing that's in your blood. So it is bioidentical. We just don't call it that. The other thing is that we know the exact dose. We have studies showing how your trying to do something.
Uh-oh.
Sorry.
We lost you.
Sorry. We have studies showing how your body's going to react to that medication. The problem with compounded bioidentical hormones that you usually have to pay a lot of money for is that oftentimes they have really high levels of different hormones that are not safe for patients with cancer. And sometimes, and there's a question about insurance coming up. If you see a specialist and they document that you have early menopause, which is also known as premature ovarian insufficiency, then sometimes you can get insurance coverage for hormone replacement therapy, because we know that putting women in menopause in their 30s can have long-term effects on their bone health, their heart, and their brain.
And of course, psychologically, it's not an easy thing to go through. Someone earlier, if you can go to just your regular gynecologist, or do you need a specialist in this? And I think you kind of covered that, but what do you think about that? Because not everyone will get to you in Miami, although
Your regular gynecologist should know about this, but at the same time, in the United States, OBGYN residency, they don't always get a lot of information about this. So I would recommend people that want to talk to a menopause specialist go to the North American Menopause Society website, or NAMS. You can type in your zip code and you can find a NAMS certified provider in your area. Most of them are gynecologists, but some of them are primary care doctors. Some of them are psychiatrists, psychologists,
and then they have specific understandings of the early menopause or these symptoms and things
Yeah.
like that. Okay, great. All right. I think I've covered a lot of the questions that we've got.
One of the things I would bring up is that some patients have estrogen sensitive tumors like breast cancer, certain GYN cancer like endometrial cancer or uterus cancer. And so those patients, sometimes we can use non-estrogen alternatives for their symptoms. So talk to a menopause specialist about that. But for many patients, we can still use vaginal estrogen, which helps with the dryness and painful sex, but you got to talk to your doctor and get the okay.
Right. And that doesn't get absorbed into the bloodstream. Is that why you're saying it would?
Well, we use really low doses and like give it to patients once or twice a week. And so the likelihood that it enters the bloodstream is very, very low.
Right. Okay. So now we've gone over a lot of is there anything that you think that we didn't cover today that, and if there's anyone listening that has a question where we okay after treatment to engage in, okay,
Yes.
Kristin, question. But basically you would say there's no right or wrong time when you're, is that what you would say?
Well,
Like if you're feeling cover those four things that you spoke about?
well, it's always good to think about moisturization and eliminating irritants no matter where you are in your treatment. But whether or not you can engage in sexual activity with a partner, you should talk to your doctor about, because if you're getting chemotherapy, we usually say you need to wait 72 hours before coming in contact, like if you're going to have penetrative intercourse without a condom. Most chemotherapy agents have left your system by 3 days,
Okay.
but you should just double check with your doctor and make sure you get the all clear. Sometimes they have you use condoms.
And that would be for pregnancy prevention, or is there another reason why you would not want to expose someone to the chemo that might be in your body?
Yeah, it's a bunch of different reasons. Number one, it's having your partner be exposed to the chemo agent. You don't, if they don't have cancer and they don't need it.
Right.
Two, during treatment, we really don't want you to get pregnant,
Mhm.
because then we have to stop treatment. It gets very, very complicated.
Right.
We want you to get pregnant if you're not done building your family when it's the safest, which is usually after chemo. Sometimes it's for that, but we also want to make sure that patients aren't exposed to STDs during their treatment, because chemotherapy brings down your white blood cell count. If you're exposed to an infection, you could potentially get very sick. So you want to be careful.
Right. So you would recommend condoms no matter what, it sounds
Well,
right?
It depends on everyone's situation. Everyone's situation is different.
Marital situation where there's monogamy. We don't want to assume anything, but in a relationship, maybe there's less risk of things like that.
I think it's important to have a discussion with your partner to talk about your concerns and the why we recommend certain things. Yeah, I'll leave it at that, because it can be different for everybody.
Okay. All right. Sounds good. So I'm going to throw out to everyone who's watching, if we haven't covered your question quickly, type 1 now. And for Dr. Rojas, do you think that there's anything that we didn't cover today that someone out there who might be too shy to bring up to their doctor or to their partner, anything else you think we should be covering today?
Yes. So there are a couple of things about low desire I didn't talk about.
Okay.
So we actually have, in patients where we fix the pain and we fix the psychological stuff, or at least start working on it, there are 2 FDA approved medications for low desire in women. And they usually don't have very many, they're not hormonal. One is called flibanserin or Addyi, and the other one is bremelanotide, which is an injection. So a lot of people don't know about this, but as long as you
Viagra, is that what you would say? Or
it's not women's Viagra. It's works through a different mechanism in the brain, but ask your doctor or look it up online. Sometimes through these companies, you can actually go through a doctor through the pharmaceutical program, so they can do like a telemedicine appointment and see if it's appropriate for you. And then the other thing is fertility. I know a lot of patients have fertility concerns, and so what I would say about that is, if you're diagnosed with a type of cancer where you've got to get started on treatment really quickly, it may feel like a million things are happening at that one time. But if you want to have a family or want that option in the future, make sure you bring it up to your doctor. because there are steps that we can take in parallel with all the other stuff that we're doing that can help you not only protect your ovaries from chemotherapy. So like we can actually give you an injection. Sorry, this is my dog.
I hear.
We can give you an injection to quiet your ovaries and protect them from chemo when you get them, so they're less likely to be damaged and be put into menopause. The second thing is we can help save your eggs. So we can do an egg retrieval, which only takes 2 weeks. People think it takes longer, but it actually can be as fast as 2 weeks. And so if you have 2 weeks before starting chemo, that is a really good option. Make sure you bring it up. Oncologists should now be trained to be able to refer you to the right people, get you a quick appointment. And then for patients who are looking to get pregnant after treatment, you want to talk to your doctor about when is the right time. Because if you're at really high risk of having a relapse, like right after you finish treatment, that may not be the best time for you to get pregnant, because if you do relapse, then we can't treat you. It becomes really complicated. So it really needs to be like a group discussion about when's the right time for you. And then if you're older than 30 and you have been treated for cancer and you want to start building a family, I would recommend seeing an REI doctor, or reproductive endocrinologist and infertility specialist, so they can measure your hormones, they can check how healthy your ovaries are, they can check your uterus, they can check your partner's sperm if you have a male partner, or talk to you about donors or third-party options. And so get referred to one of those people as soon as you can.
Right. So basically, you're very hopeful in what you say, and I hope that that's the message out there for everyone to hear today. Wherever you are in your treatment, you're hopeful that we can get you back on track sexually to where you want to be, or where maybe close to what you were before, and also that going through cancer treatment does not necessarily mean the end of forming a family or having a child. So to me, I'm getting a lot of hope from here today, which is wonderful.
Yes.
Thank you. Are you letting me out?
No, I'm letting my dog out.
Oh,
so the last thing, a lot of patients ask me about if they have a estrogen sensitive tumor, when it's okay to get pregnant. So yes, talk to your doctor, but we actually, for those patients, have data. Number one, fertility treatments don't increase your risk of cancer. That's a huge misconception. There's no data showing that fertility treatments increase your risk of cancer or increase your risk of recurrence of breast cancer. And we now have data as of the last year showing that for some patients, it is safe to get pregnant after breast cancer treatment after 2 years. And that means stopping your estrogen blocking medication temporarily to get pregnant if that's your goal. So things are changing. Like, we're dispelling myths. We have specialists, so just make sure you ask your doctor for them.
Okay, and Sammy from Miami, so maybe Sammy, you can go find Dr. Rojas, is asking about her IUD, and should she take it out post-treatment to give her body a break from everything that's been in her body. Do you see, prior to getting pregnant, is that something you would recommend?
So you can get pregnant like right after taking out a hormonal IUD. Hormonal IUDs, the ones with progesterone, actually decrease your risk of uterine cancer, ovarian cancer, colorectal cancer, and there's very little hormone absorbed by your body. Like, there's this concept like you should give your body a break. But your body's probably getting a break with that IUD in place because it's keeping the lining of your uterus or the endometrium really thin, so you're not having really heavy periods. And IUDs do not change your fertility. Like, you can get pregnant the day after removing your IUD. Yeah.
Okay. Good.
So that's a really personal discussion with your own GYN, but so I can't give medical advice, but those are some thoughts. Yeah.
So Sam, bring it to your doctor. Dr. Rojas may have covered some of that for you. Okay, so we have covered a lot today. This is all very hopeful. Yes, it is. That's exactly what I was saying. And so I can't thank you enough, because you've made me feel hopeful, even in to know about these other areas and things that I can talk to my patients about when they're going through or having gone through treatment. So hopefully the message is of hope. Thank you all for saying that. And hopefully one where we have spoken so candidly and freely today, and that you can take this message and just, this is part of life. It's part of your body, and take it to your doctor. Like, it's scary to think about it, but yeah, so let's see. I'm a patient of Natalie and Dr. Rojas Group.
Yeah.
Okay, nice. Coconut oil. And I just learned that too. Well,
Yeah.
know about
Coconut oil is good for everything. Put in your hair, your dry skin.
right. So we can go cook a little dinner and then have after dinner.
Yeah, best time is after showering. And really, so someone was asking about soaps in the vagina.
Mhm.
So the vagina is the inside part, the vulva is the outside
Mhm.
part. So I tell patients the area that has hair, you can wash like the rest of your body. The area that does not have hair really should not be exposed to soaps because it kills the good bacteria. So you want to wash with water and get in all the like cracks and crevices,
Mhm.
but you should not be putting soaps in the vagina.
Okay.
Yep.
Okay, great. And Sammy's also asking, do you have an individual Instagram? Do you have an account?
Yes. So this one is more like my breast cancer and genetics focused Instagram at Kristin Rojas MD.
Okay.
But we have a special Instagram just for our music program where we talk about a lot of these topics. It's at music_sex after cancer.
Okay.
So,
and just quickly, for anyone who just logged on and is thinking that music is music that we listen to, can you just redefine music again? That's your program, but
sure.
For?
It's not like choir or drum circles, which some people like think they're getting to when they come to music clinic.
Okay.
It's menopause, urogenital, sexual health, and intimacy clinic. Our home base is at Sylvester Comprehensive Cancer Center at University of Miami, but we do telemedicine. I have an amazing team, and we have our music program Instagram at music_sex after cancer.
Wonderful. Okay, thank you. And for anyone else, you're on the CancerBuddy app part of Instagram, and so that's part of the Bone Marrow and Cancer Foundation. And then there's a separate Instagram, which is the Bone Marrow Foundation. So you can follow us there. And if anyone here has not yet downloaded or uploaded, whatever you're supposed to say, the CancerBuddy app, it's a way for you to connect with other people who might be going through similar things, or you might be in the same city, or you might be the same age, or whatever. So it's a wonderful thing to download it, or if you can. So anything else? Anything else, Dr. Rojas?
We've covered a lot of ground. You know, I think that for many patients, I get asked a lot of very specific questions. So I think these are all general concepts, but sometimes your situation is a little bit different. But I would encourage people to seek out resources like you've just mentioned, talk to other people. There's some great like young, well, I know a lot of breast cancer young patient resources, but I know there's some similar ones for hematologic malignancies. The sarcoma Alliance has group, like a lot of these organizations are putting out a lot of this content. So make sure you try to find a reputable organization. You may not always get good advice on Reddit or Facebook chat or Facebook or
in the middle of the night. Try not to do that
there's a lot of misinformation out there. So get out there, find the information, find the resources, but just be an educated consumer.
Perfect. And I'd love to end with, someone said you're the best, but also Carol said she's excited to get back on track after coming out of her bone marrow transplant. So I think that's the message of hope and moving forward and getting back to some sort of sexual life that you had before, or excited to try something new for the future and try your coconut oil.
Yeah, coconut oil or hyaluronic acid suppositories. There's one by Bonafide brand, but there's also a CVS brand, $12 a box.
Oh, wow. Because I know the Bonafide is expensive. And for everyone wondering, it is the same ingredient that's in all these face creams like Jennifer Garner is advertising other people, but don't use that one. Use one specific for
Vagina.
yeah. Okay. Well, it was so nice to meet you here, and hopefully everyone enjoyed meeting you and hearing from you. It was wonderful, wonderful to chat with you, and that's it. Anything else to add, Dr.
No,
Rojas?
just thank you. It was so nice chatting with you. Thank you for all the amazing work you're doing. Thank you for having me on. I just thanks to everyone who is listening for your time, and feel free to reach out on the Instagrams.
Okay, wonderful. All right, take care. Thanks so much.
Bye.
Bye.